It's a really great honor to be here. It was a surprise invitation sometime in December when Professor Binder and Herr Klinich contacted me if I can bring a presentation on music neuroscience and the applied applications to neurorehab to the Adeli Center. So I'm very glad to be here. It's also my first time in Slovakia, so this is a very nice discovery for me. I'm at the University of Toronto in the Faculty of Music and in the Faculty of Medicine, and been doing research on how the brain processes music and how some of these mechanisms in the process of music perception and production, how they can translate actually into very effective applications to neurologic rehabilitation. Neurological rehabilitation, really in the broadest sense, then everything that we do or not do is based on the brain. Before I get a little more into the actual science, I want to maybe give you a little bit of an orientation about the music in the role of the human brain development. We have sometimes very romantic notions about what music is. Some of these are really very recent. The idea that music is some sort of mystical, emotional system is maybe 200 years old. Before that, music was actually viewed in a much more complex way. And actually for the most known history of music was actually considered a science. It was in the medieval quadrivium, arithmetic, astronomy, geometry, and music. It was a science. Anyways, interesting here maybe to orient yourself to what music in some ways is in the human brain development. These are bone flutes. They're 45,000 years old. And we also find ivory flutes. But what is remarkable is that this piece of wood has 5 bore holes. In other words, that is a modern flute. And what's even more remarkable is that these bore holes are in relative equidistance. So how did they figure that out 45,000 years ago? It must have taken a lot of experimentation because we are not familiar with any kind of measurement or technology at that stage. This is actually acoustical engineering tens of thousands of years before modern science and technology get into the picture. This must have been an enormous amount of effort of the brain to create something that creates sound, which in many ways is purely abstract. And then, of course, the idea of the human brain to engage in abstract sound patterns is a requirement for higher levels of cognition. We also find very interesting visual art, statuettes, and things like this in the ground. In the music, we can only deduce how the thing sounds from the instrument. And it must sound actually very modern, because that instrument cannot be played, but if we would recreate that instrument, it would be playable. There's no problem. The other interesting thing is you never find an instrument by itself. You find hundreds of instruments in the vicinity. So now you can speculate why that is. Either there was a very, very, very rich Neanderthal who owned 100 flutes, or there was actually early orchestral music. People played together. And I would say probably go with the second hypothesis. Music is a hardwired biological language of the human brain. We can firmly assume that, and so we have actually a very good rationale why we can then also use music to rehabilitate the human brain or enhance neurodevelopment of the young human brain. So to context that a little more, when we talk about neurorehabilitation, an interesting angle is to call neurorehabilitation applied neuroscience. So in other words, what do we know about the human brain, neuroscience, and then applied to rehabilitating. So in other words, when we talk about neurologic music therapy, then we can call that maybe more succinctly applied music neuroscience. You will see in my presentation some brain slides, some research data, but I also like to sort of insert some of the videos because that tells the story even more clear. So, applied music neuroscience, and that is really what's behind the term neurologic music therapy. So there are four mechanisms that you will probably see in everything that I do here this morning in terms of fundamental mechanisms underlying how music, the neuroscience of music, actually can be translated into rehabilitation. One is rhythmic entrainment, locking the motor system into the auditory system or locking the cognitive system into the auditory system or merging language and music networks in the brain. So inducing temporal order in oscillatory networks in the brain. The auditory sense is the fastest, most precise time processing sensory system we have. The eye is fairly sluggish. Tactile is a little better. The auditory is built for rapid time processing in the brain, early on in the system. So it makes very much sense if we want to rehabilitate, enhance, and retrain things, motor systems, cognitive systems, they all have something to do with time. Okay? In movement, it's the easiest way to see it, but also in cognition and language. Everything is time-based, and so it makes perfect sense, actually, to use elements of music, especially rhythmic elements, to induce that kind of improvement. The second big brain mechanism is to make thinking and feeling and moving and talking audible. Augmented auditory feedback, and what that means you'll see in some of the videos very easily. And feedback is one of the most important things in learning, but precise feedback is also very important in the relearning, and this is what we look at in neurorehabilitation. The third thing we found is very interesting. When we put people in the brain scanner, the whole brain essentially becomes connected and synchronized and lights up in synchronized fashion. So the music induces a widely connected network of regions that are working in a synchronized network fashion, and then can also induce plasticity, neuroplasticity, which is one of the mechanisms we're looking for in neurorehabilitation, to change the brain or restore the brain, not in a compensatory way, but in a sort of functional impairment way. And then the fourth big pillar is very important for rehabilitation is motivation states. The patient has to be motivated. That is very important for the success of rehabilitation. And we know that the motivation networks are not just sort of in their own little emotional world. They're connecting functionally to cognition, motor, etc., etc. And so in that sense, of course, when you bring music into the rehabilitation arena, then you have a big bonus there because music is motivational. If you pick the right music or the right elements of music, then it is motivational. I'll give you a little example of that. 3 years ago, we did a fMRI study with Alzheimer's patients. We want to see what are the networks why people remember music that they've known for 20, 30, 40 years, still remember well, and they don't remember what they ate 5 minutes ago. So we put people in a brain scanner, and there were about 20, and then they had to come back and go back 4 weeks later in the brain scanner again. And going into brain scanners is not the funnest thing in the world. We thought we would probably lose 10 out of the 20, but they all came back. So they were highly motivated to help with the research, but also saw the benefit in that. So rhythm, entrainment, feedback, plasticity, and motivation are the big pillars that we have been able to establish in the last 25 years. And that really has moved the traditional music therapy into NMT, which is really a very, very different field. I will talk about more of that during the workshop because that becomes probably more relevant for people in the workshop. NMT is basically, we developed 20 interventions that have research evidenced. Actually, some of the guidelines in the US and in Canada, and the stroke care guidelines. And then the World Federation of Neurologic Rehabilitation also has given the Academy of Neurologic Music Therapy institutional membership. So NMT is actually a medical partner in this field, which is very, very nice to see. I'll talk about that more during the workshop. And here's a little overview. NMT is really practiced in about almost 70 countries in the world. And we feel very strongly about the idea of being here and introducing that from a science point of view, but also from a hands-on point of view, because Eastern Europe has been basically somewhat underrepresented so far. Hopefully we can make a change in that. So that's for the workshop. So this is important to understand that when we listen to music, when we produce music, I think there's a common agreement among my colleagues that music is one of the most pervasive stimuli to trigger a lot of different brain regions at the same time. So music processing is not there's not a music system that processes music in the brain. Music processing involves core cognitive, motor and language systems of the human brain. So we really have access to the core regions that we need to address in rehabilitation. And the interesting thing is that they're not just sort of light up in some kind of Disney World function, they're actually synchronized and light up in some kind of coherence, which is very important for crosstalk in the brain. That's the auditory system, and that is probably, as I said, that's the fastest sensory processing pathway that you have in the human brain. From here, from cochlea to the brainstem, and then into the subcortical and cortical regions, and then widely connected to the rest of the human nerve, the central nervous system. And this is a very interesting microimaging picture. This is the a big important pathway is called arcuate fasciculus. And here's the auditory cortex, and then these fibers travel into the frontal and prefrontal cortex, connecting, for instance, with executive function, with language. But the orange stain here, those are actually synapses with motor neurons. So there's a very direct connection between auditory input and how that can drive motor output into different kind of states. That system is active, and if you stand, let's say, at a restaurant with a lot of loud music, everybody taps their foot. Everybody taps their foot, and you have no idea why, and you also may not even recognize that you are tapping your foot. Well, I can tell you here, the orange part. That's where the auditory neurons fire in synapse with the motor neurons, and then the motor neurons start firing in actually the auditory rhythm. Another way to look at this is quickly here. People are tapping. These are healthy people. They're tapping. This is EEG. And so they're tapping self-paced. And you can see the motor neurons firing, a little fuzzy. Then they listen to a metronome, a beat. The auditory neurons fire very, very precise. And now they're tapped to the beat. And this kind of fuzzy motor signal becomes a highly well-focused, well-defined neuronal output, and that also translates into very precise hand movements now. We'll go through that. And so this is basically where a lot of that thing started. In my first life, I was a professional violinist, and then after 6 years, I thought I needed a sabbatical. So I got a Fulbright scholarship and went to the US and then studied, I thought for a year, music psychology, music therapy, music theory, just sort of outside of a performance, but still in music. So I became very intrigued with some of these things that I saw or did not see, because I did not see what I thought would be more scientific foundations of how music actually operates in therapy. So as a musician, I wanted to come from a different angle. And I thought, so one of the most important things for me in motor training and learning is rhythm, timing of movement. Has to be very precise and very rapid, and has to be remembered well, lots of movements, in order to perform well. And so I thought maybe we can test something here with rhythm that goes beyond that more surface emotional well-being concept what music is supposed to do in therapy. We did sort of an experiment, motor system versus sensory system. Okay, gladiator in the brain. Whoever wins, I'll stay or go back home and play the violin again. So we used auditory rhythm, and we tried to pick the most arrhythmic but consistently arrhythmic movement we could think of, and that was the hemiparetic stroke, walk of the stroke patient. So the rhythmic beat is tap, 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 and if you look at a paretic walk, is short long because the weak leg, the strong leg. So it's basically like boom, 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 boom. So I'll show you a video after these data, and so we thought we're gonna have a stroke patient walk to a rhythmic beat embedded in music to make that rhythm feeling not stronger. And who wins as the motor system ignores the auditory input, or the auditory system actually can reshape the motor output. So anyway, the data are here. Those are two landmark studies with comparing RAS, rhythmic auditory stimulation, that's what the intervention is called, against the traditional PT interventions, NDT Bobart based, and in all, after 6 weeks, gait parameters were significantly better with RAS. And that was, people sort of started training somewhere between 2 to 4 weeks post-stroke. So it was subacute. And then we repeated this whole thing in a multi-center study 10 years later, and we had the same amount, same difference, but a smaller magnitude because the lower training here was only 3 weeks. So that has sort of set the standard then for RAS becoming a very, very effective application in stroke gait training. And I'll show you actually in a workshop how to do this, so maybe we can integrate that here too. This is a very old video, but it tells the story quite nicely. And here at this. Okay, so this is one of the participants of that first study. Our lab looks much nicer and cleaner now, but back then we had foot switch mats and all kinds of stuff. Anyway, that was like 25 years ago. Anyway, so this is a stroke patient, 4 weeks post-stroke, in the with the left hemiparesis, right parietal stroke. So you can see the paresis very clearly here. I don't need to comment on that. Okay, that's from the back. Okay, the center of mass rotates from left to right, not enough forward. And so this is immediate moment of rest and then walk, and now we turn the music on. And the walking pattern changes completely. And if you look at the left leg, it also tells you why. So there's something in the perception of rhythm that actually changes how the motor planning all of a sudden starts, because the patient knows, the brain knows, there is a beat coming up and I need to get my leg on the beat in the next 800 milliseconds or so. So the preparation, predictive preparation, changes completely, and he actually starts moving his weak leg earlier to get the symmetry. Okay. So it's absolutely fascinating. It has nothing to do with instruction, because we could not instruct him or explain that to him. That is actually pure rhythm auditory perception. And so that's the post-test of that research study. And of course, pre and post are always done without the stimulus. The stimulus only there for the intervention. And so this is about 10 weeks post-stroke. And I'm pretty sure you agree that this is actually very nice. Okay. So this is a traumatic brain injury patient, and that I want to show you for several reasons. Because I was in Ecuador a couple of years ago in Quito at a neuroscience symposium as a speaker, but the neurologist organizer, Nelson Maldonado, who you can see standing right here, is building neuro rehab up in Ecuador, which does not have neuro rehab. So once they're out of the hospital, they go back to their towns or villages, and there is no further anything. So this gentleman here was on the treadmill when we walked in there, and he was basically just hanging on the treadmill, and the treadmill moved his legs. So Nelson asked me if I could do something with RES, since that's sort of my research thing. So we took him off the treadmill, and he had never been really off the treadmill trying to walk or stand. And then I had to instruct the assistants who were not PTs where they need to walk with them. Somebody has to be in the back, etc., otherwise they didn't know that. So I did a little bit of that, but then you will see some also very, very, very interesting. So this is a TheraPans. It's like the idea of a gait belt, basically. It's not a gait belt, but the idea. So, and walk behind, not on the side. So he's supposed to walk, and that doesn't look very promising. And then I sort of eyeballed his step frequency, which was about 50 steps a minute, and then all we did was this. There you go. Glad I showed that to them. Okay. Oh yeah, that's an immediate effect. The auditory rhythmic input starts activating the motor neurons. They fire in synchrony, and then the legs start moving. And this was not there was really no cognitive effort or instruction involved. He probably would not even have understood if we say walk to the beat. He was not at that stage. But he starts immediately to move to the beat and to... So I don't speak Spanish that well, but it sounded to me like everybody was excited. And the fascinating thing is, if you look, sometimes he misses a beat, and he waits, and then he steps to the next beat. So this is what I just showed you with the blue and the orange fibers. That's where that happens. That is entrainment physiology pure. Okay, good. Very important discoveries. We made them as discoveries because when we started writing the papers, we didn't really have a lot of literature to fall back on in terms of we are confirming that Watson and Miller did the same thing. No, we knew we were the first ones, and we had to very interestingly pick our reference list for the papers. And so now that is standard in many, many hospitals in many countries, and so we'll work on that this afternoon. That's in a clinic, Parkinson clinic in Germany. Okay, so classic gait picture, bradykinesia almost freezing, etc., etc. And here it is. So we did fMRI studies, more with hand movement, and we know that the basal ganglia is dysfunctional to a certain extent, so we see suddenly the cerebellum becoming sort of a partner in driving this kind of change. Here's a very dramatic picture, fascination. This gentleman is bound to fall at some point in time because he's just walking away from a stiff ankle that goes forward. And so this is the immediate change. So anything with gait and movement needs to have the auditory system involved. And we're going to work on that in a little bit. So we did a falling study actually, and the falling was reduced. The training stayed were maintained by the patients for about 3 to 4 weeks, but it's neurodegenerative. So then it started declining again. And this is the falling study. We can skip here. And now we did also upper extremity work, and we can see how the auditory signal here in the auditory cortex and the motor output here, pre-test and after 4 weeks of training, this coherence of these two systems firing together, driven by the auditory system, has increased significantly. We did some neurotransmitter imaging that's very rare, and that's not topographical fMRI imaging, that's dopamine imaging in PET, and we found that actually the people with the self-paced tapping actually required more dopamine uptake, whereas when the auditory system and the auditory rhythm was pacing the movement, then the dopamine uptake was reduced, which is, of course, nice, because then that shows that there's less reliance on a dysfunctional neurotransmitter system. So we're still doing this more because it was interrupted during COVID, because I couldn't not do that stuff during COVID. And then we are also doing something very interesting. We are actually one of the teaching hospitals at the University of Toronto does a DBS surgery, implant surgery for Parkinson, but they do it in separate stages. So the implant is put into the basal ganglia area, the globus pallidus, and then the wires are exposed for 2 or 3 days. So there's a lot of testing going on, and then it's all buried. So we had a window to actually measure intracranial, intercellular responses direct from the neuron. And this is what you're supposed to see when people move rhythmically. We see a desynchronization of the neurons before the beat, and then you see a resynchronization. That sort of term shows the movement is over, preparation for the next one. And we don't see any of that during self-paced movement here. It's blue, blue, blue. But when we add a rhythmic beat for the movement, then this beta rebound here is restored. So fascinating stuff. What we can do, I'm going to skip that part, because that is network science, so the neighborhood research in the brain. So it's very interesting what the auditory system, and especially in in patterns, acoustical patterns, which that's music, elements can do, how to retrain and reshape motor output. And so this is a very, very important contributor to movement and motor rehabilitation. So upper extremities, there we have developed an intervention, or tested an intervention pretty extensively, mapping functional movements onto musical instruments. Usually big percussion instruments, because you get nice targets. And so the idea is that now in terms of rhythm, we're adding auditory feedback. If you complete the movement correctly, then you get a sound feedback. So you know I did it right. Okay? Making that movement audible. And then add the rhythm for the predictive stability, and then you have a beautiful setup. Very effective, and we just completed a dissertation on that a couple of years ago. It was stroke, subacute stroke. And that is a typical setup where actually the patients can work with each other. So we'll work on that later. We have the instruments back there. And same thing. And this is from Tanzania. It's very simple technology. Each of these tambourines costs at least 500,000 euros. And extremely effective. That was actually a joke. Extremely effective. Therapeutic instrumental play. So, and then they can actually work together. Okay. So each of these movements is functionally determined. It's not just random hit the drums. Okay, and then we actually have technology here developed as a soundboard that creates sound when you do it. This is the study that we can kind of skip. But I want to show you this because that may be a nice picture relevant for here. Okay, so it's the kids love it, but there is some very serious business underneath, okay? Because the instruments are placed exactly where they need to be in order for the shoulder extension or whatever, the elbow flexion, etc., etc. And so when you do this right, then the kid gets feedback for proper execution of the movement, and that is what we call technically sonification. And that is a very, very effective, and there's studies out there that have shown that, and some of our studies too, that works really, really well. Here's another picture of that. It's a little more chaotic, but the same idea. Okay, and then here. Okay. So get the idea from the musical cue. We associate rising pitch with up movement, although there's really nothing up, but so our brain associates that. And so we can actually also translate that very effectively into music. This is a little more difficult. You probably have to have some music background to play the piano stuff, but the other things that you've seen can be executed by any rehab professional. I will show you how. Okay, we have go into speech a little bit. Melodic intonation therapy is very good for non-fluent aphasia because we know that it changes the hemispheric process. So that we can see that here. That's from a friend of mine, Gottfried Schlauch, who did some research on that. This is a 12-year-old girl that had a hemorrhagic stroke. They started functional word singing, sentence singing, and so everything went over to the right hemisphere, the undamaged right hemisphere. So the arcuate fasciculus that you saw earlier, the blue and orange, it's there, but it's really not activated yet. And then after many sessions, you see how this emerges through melodic intonation therapy as a functional pathway to restore speech. Let's look at a Japanese MIT application. So this is the classic picture of Broca's aphasia. They understand, and they try to say it, but they can't encode it in the area in the left hemisphere, in Broca's area. So then she sings with him, and he joins spontaneously, which is a good little assessment. And now the session is pretty highly structured in terms of presentation of the keyword and then singing and singing back. So now you all learn a Japanese word, konnichiwa. So now he initiates himself. So that goes through a lot of different steps. We can practice that this afternoon a little bit. And then at the end, what do you say when your friend comes in? So no music, no singing. Although a lot of patients actually do go back to singing, but that's fine. As long as it's comprehensible, intelligible, that's fine. Okay, so there are a lot of other applications in speech language because obviously the production system for speech language and music, singing or playing wind instruments is very similar. So this gentleman actually has 2 strokes and he had problems with swallowing, dysphagia. So he has no control really over the oral motor and respiratory network. So it doesn't work. So now we make this whole thing audible in NMT. And we need a lot of very expensive technology to do that. So there's a little harmonica. So it's the principle of wind playing, wind instrument playing, brass instruments playing in music. There it is. So we have made that oral motor system audible, the correct positioning. Now he actually hears and gets feedback how he has to organize that system. Okay, augmented auditory feedback, and now no problem. Okay, muscular dystrophy. A very effective and also very enjoyable way for him to practice his respiratory system, respiration. And is also now organized in time, because the rhythm, the phrasing of the melody, blow, da, dee, dee, he prepares and then he blows. So the rhythm applications go across the board, not just for the legs and the arms. So it's a very effective way. We actually have an instrument back there that we will use later in the workshop. Okay, so now he breathes in and knows when to breathe out. The last area I want to talk about is music and cognition. That also includes language, because obviously language is very cognitive, one of the highest cognitive functions we have. So this is an interesting study from a group out of Columbia University, and they did some work with autism spectrum disorders. So they had a typically developed child, and then as a control, children, and then autism, and these kids listen to the voice of their parents speaking. And fascinatingly here, the control kids have the language system here. This is reversed, of course. So on the right of the left side, language system active. The autistic kid is silent. The language system per se is silent. I mean, they listen, the auditory system's there. But when they hear the parents singing, the healthy kids sort of drop the language system and everything sort of switches a little scattered to the right hemisphere, where they probably just enjoy listening to their parents make music. Whereas now the autistic kids here, that system now is active. Okay, so it's a very interesting effect of music on the language system of those kids. Okay. And here's another kid, and well, it always says what the kid's working on, so I can't really ask you that. So most people would say the kid practices something with the arms. But that's actually, the arm business made really easy for him, because what really this exercise structure is driving and stimulating is his sustained attention system, because he has to listen to every beat of the blues, but he has to then also listen when the chord changes. And then he has to find different tone bars that are color-coded, so they're easy for him to find. Okay, so listen in. Good. Did you hear the chord change? Okay, back to the... So there are lots of exercises that you can set up with the same structure, and they're very effective because they make now attention audible. Because when he does it right, then he hears it and the therapist hears it. Okay, and we know from brain scanning with exercises like this that the more we do this, the more we drive the dorsolateral prefrontal cortex in the executive system of the brain into activity, which is where we want things to be. Okay, this is interesting in terms of disorders of consciousness. The last 10 years have seen quite a bit of more and more research, brain imaging research, EEG, fMRI, with disorders of consciousness. And then also the question is there anything that music can meaningfully trigger in the brain, although overtly you don't see anything in vegetative state or in minimal cognitive function. So this is an interesting study from colleagues of mine in France. And these people are 6 MCS and 7 VS, so they're pretty severe, post-comatose. And they listen to either a preferred familiar music that, is their favorite music, before they hear a list of first names, and ever so often their own name is randomly interspersed there. And then the control condition is white noise. So priming the brain with favorite music and then see what response will be there. Okay, so in the music condition, it's actually very interesting that 7 out of 13 patients have a distinct cerebral response here in the EEG. The N200 and the P300 are associated with discriminated responses in the brain. So this is something you don't see. They are not like, oh, that's me. You don't see anything behaviorally, overtly. You don't see anything, but in about half of the patients, you see a distinct cerebral response to the priming through the auditory, the favorite music thing. Then if you see this, that's pure random. Of course, that's the other 6 that didn't show anything. And that was also shows it with not so good recovery. White noise per se, just an auditory stimulus, even if it's spectrally very rich, doesn't show anything except in one patient. So it's not the auditory stimulus, it is some kind of association of my favorite music triggers some kind of response. So these are very interesting studies, and we're trying to actually set up a study in that nature around my research lab in Toronto with a group that does DOC research. Okay, we'll go over this here. We'll save that for the workshop. And I think I'm going to show one more thing here. That's, I think, probably also similar to our RES research, a landmark study, because it's well known in observation that a lot of dementia patients, Alzheimer patients, remember music, but don't remember anything like within minutes, but have a memory saved, preserved for 25, 30, 40 years. So we did a study with one of the teaching hospitals, and we had them listen in the brain scanner to a playlist of their favorite old, still known, recognized music. And then we had composed new music that they have only known for the first time an hour before they went into the brain scanner. So we have a 30-year memory versus a 60-minute musical memory. And the outcome is very, very impressive, I would say. The blue is the 60-minute music memory. It's basically auditory centered. It's a sensory memory. There's very little scattered stuff around. But the memory for the old music is deeply, deeply encoded across the whole brain bilaterally, including areas, basal ganglia, cerebellum, that are not affected by the Alzheimer deterioration. And then we also see prefrontal areas. So we assume that some of that comes from autobiographical associations. And then we did neuropsych testing after 4 weeks of listening, and they improved in the memory scale. And that was very surprising because this group doesn't really improve on anything. And then we did some connectivity and white matter analysis, and we saw also increases in post-intervention in micro white matter density. So there is a very profound effect of music, a different way of using music. It's not a rhythm and walking. It's not singing and breathing. It is cognition and music to affect the memory system in positive kind of ways. Okay, that is something we will discuss later during the workshop. How can we bring these techniques in some kind of adapted fashion to the family, to the caregiver, so that we have the family and the community part of our team, because in many countries in the world, even here, the sustained intensity of training is not enough, because once they get discharged, then they go in the lucky cases, in countries like here, they go to the therapist once a week, but in other places like India or Nigeria or Ecuador, they don't see a therapist for another 6 months. So that's not good. And so we believe, and we're doing a big study in India right now, we believe that NMT interventions can be scaled down and still be impactful to give the family, the caregivers, a toolbox to work with their people. So that's my lab. It's too big. I have too many PhD students. And I have a research coordinator, I have postdocs, and lots of collaborators across the campus, but also across other parts of the world, Germany, US, India. And here is a little clip while we're doing all this. This is an application of RES to Parkinson, but it would probably work also for other conditions, of course. So the traffic light turns green and she can't move. Classic freezing in Parkinson. So we need major technology. The gentleman with the metronome is actually a neurologist in Norway. So she gets across. Okay, so that's try to give you some scientific and theoretical, but also some application illustrations, so that you not just see bar graphs and lines and brain regions, but also that stuff really, really can make a difference and it really can work. So I would say time for questions.
Hello, thank you. Maybe it's an awkward question, but I have to ask, I'm sorry. What about a patient which is deaf? How do you work with them?
Very interesting question. I actually have a video from a person with a cochlear implant and a training, because we do a dissertation with cochlear implant and restoring speech perception. But there are a bunch of different auditory channels. We have bone conduction, we have vibrations, etc., etc. So you can actually stimulate the auditory system. So alternative channels too. And also a lot of deaf people are not 100% deaf, they're deaf in certain frequencies. And so that's where you can actually sort of tailor some approach that can trigger auditory function, although in some different ways.
Thank you very much.
It's maybe my conjecture, but if there are professional musicians who are trained for that synchronization, are they more affected with neurodegenerative diseases? Is there any study about professional musicians?
Okay, so I think the question is if professional musicians respond better to that kind of intervention. No, it's because most of that is really based on basic cognition and physiology, so it's not really a skilled thing. So like I walk rhythmically, dancing would be a little different, but these basic functions, everybody responds the same.
Je možné, že je niekto arytmický od narodenia, že skrátka nemá v tele ten rytmus. Ako potom?
Patients, the functions we address here are rhythmically hardwired in walking, for instance. The brainstem and the spinal cord, they're gait generators that make that we walk rhythmically without thinking about it. We're just trying to restore that through the rhythmic input to the auditory system. With the arm movement, they are not intrinsically rhythmic, so we have to create a pattern, like a reaching back and forth pattern, for instance, or an abduction pattern. And then we can integrate and we make that, guide that with it. Rhythm is a timing signal, okay, and so the brain does respond to that. It's not a skill. Like if I want to teach you tango or waltz, some people are better than others because that's a skill. But what we are addressing in therapy is not a skill. The rhythmicity is important, can be restored functionally.
Hi, I got a question. If there are any studies for the unborn babies, if this NMT is any way stimulation for them, for their healthy development?
Yeah, no, there are no studies. I mean, we know how the auditory system in the fetus develops. And it's so relative monotonic and not directional. But the auditory system matures is pretty well equipped when the child is actually born. So there's still some myelination going on. So that the child hears in certain frequency, the baby hears in the uterus, in the womb, they hear. But it's if our understanding is correctly, it's a fairly kind of fuzzy hearing that's also overlaid by a lot of internal hearings from the mother's body, because that's a very noisy system. So the idea of have the kid listen to Mozart before born and then it turns into a genius, it's probably not going to work.
It depends on what genre or type of music they're listening. They react on some of music better than another, or it's just a rhythm. Rhythm is important.
That's a very important question. It really depends on your application. So if you do, for instance, if you have addressing the more attention and cognitive system in the brain, then it's very important that you use preferred, familiar, etc., music. So that makes a big difference. In, let's say, the motor division, the motor domain, the genre doesn't matter. The kinematic accuracy of the cue matters. Now, so it depends really on, music is sort of like a toolbox. It has so many different elements. And then you need to pick out the right ones. If you work with Alzheimer and memory, then the music has to be familiar. Or if you work with disorders of consciousness, yes, the music has to be familiar. But if you work with gait and stroke, the most important thing is that the rhythm matches the step frequency. If they're trained with that over a long period of time, you get more motivation if you use music that they're familiar with and they like. So if you want to have them walk every day for 6 weeks, and they hate jazz, so don't play Duke Ellington. So play something that they are familiar with, and that's also very important when we translate NMT into different cultures, like Indian music sounds very different, Japanese music sounds very different, etc., etc.
If you have a child with small cerebellum, can the therapy work also so well?
Yes, I think actually it should work really well. The cerebellum is a very important structure in the brain, so it's like an optimization system for everything. But the interesting thing is that when we put people in a brain scanner, any type of music engagement, just listening or tapping a finger or God knows what, the cerebellum is also strongly activated. So it's very fascinating. So you could make a case for that in terms of if that system is underdeveloped, it will be activated and engaged through focused musical activities and exercises. That's for sure. And so then the hope, of course, is that over time there can also be some plasticity in that system, in the cerebellar system, to make that more functional and bring it to higher neurodevelopmental stages. Music will engage the cerebellum. Anything in music will engage the cerebellum, which is very interesting. So it may be. So this is actually one of the hypotheses when people in NMT work with autism spectrum disorder, because one of the hypotheses that I think is correct by now is that the cerebellum is sort of the center of a spoke system across the brain that's not functioning right. So the brain of the child with autism has not enough long-range connections and has a lot of small world connections in the brain. But with music, we can actually address exactly that network because it gets into the cerebellum.
Thank you. So I actually have several questions. The first one would be, you mentioned some brain scanning functioning studies. Have there been also studies which looked at, let's say, some systemic parameters, blood testing, inflammation parameters, like clear markers of some success in blood, let's say?
Yeah, before actually brain scanning, the biggest research, physiological research in music was sort of autonomic responses, blood, you can galvanic skin response, EMG, heart rate. So that it doesn't give you that much information as actually looking into the brain.
Many years ago, during the 50s or 60s, the Karajan Foundation in Salzburg has done many research concerning these questions, autonomic functions. Very interesting publications from this foundation.
There is a parameter called heart rate variability. Is there any link between applying music and changes in this parameter?
Yeah, I mean the heart rate will change when you listen to music. That's pretty clear. The question is, it's a little idiosyncratic, that whole thing. I've done in my early stages of my career, I've done some, ANS research, and so in association with like relaxation responses. And the interesting thing is that people listen to they're sat still and then they listen to their favorite music as opposed to relax. And the heart rate went up from 55 to 65 or 70, and they said, I'm so much more relaxed. So how that is, it's very, very idiosyncratic interpretations of own status. So relaxation doesn't necessarily mean my blood pressure goes down, my heart rate goes down. No. It could actually go from a lower state of arousal, it could actually go up a little bit. So music is basically, you have to use that, you do it yourself basically, whatever makes you feel good. And then that's probably effective for whatever goals you have in terms of uplifting or relaxing or that kind of stuff. Yeah, but that's not research. I have not looked into that part in 25 years.
What I actually meant is, you have this heart rate variability, which means there are those small differences between the frequency of the heartbeat and I was thinking that maybe in some way it would be possible to synchronize, lower the differences in these variations with applying like some synchronized music, basically some metronome or something like that.
Yeah, there are some studies that have actually looked at that, but not that many, because the question is really, when we do translational research, we look at is there a functional issue? Do people actually benefit when I have my metronome ticks at 80, my heart rate synchronized at 80 beats a minute? So I don't necessarily see a benefit in that, but also what I see in the studies is that the ANS is pretty self-regulated. And it wants actually to do what it needs to do to feel best. So it would be kind of, I would say, maybe dangerous if I have a secret metronome here and I get all your heart rate at 90 or 100 rather than regulate yourself. Okay. So there have been studies with respiration, breathing frequencies, trying to train that with rhythm. Doesn't work well. The ANS is pretty in control. That's why it's the A.
Yeah, I see. 2 more questions, if that's okay. I hope. So, first of all, is there any link between somebody was musician and then they get a stroke? Is there any link between brains that are musically inclined, let's say, and average people in terms of the response to musical therapy?
Really, actually, we have never seen that, which makes me actually happy, because if otherwise, would be an argument, well, you have dementia now. If you would have played the piano more when you were 10 years old, then we could have prevented that. So fortunately, these applications work at any stage with any background. Now, musician brains, intense professional musician brains, do get wired a little differently, like the hand areas or whatever. There's changes in white matter density and also structural changes through training, but that does not necessarily give you much of an advantage when you have a stroke. Actually, half of the people in the study, the Alzheimer's study, were actually musicians with Alzheimer's.
The last question would be, there is some difference between this normal way of tuning instruments, 440 Hertz and 432 Hertz. I don't know, maybe you are familiar with that?
Yeah, the frequency tuning of the A has moved through the centuries. 440 is modern, and earlier tunings in the Baroque, the A was at a different frequency. So that's that has changed.
So you would say that there is no evidence pointing in the direction that it makes a difference, basically, or
difference in what?
In terms of, let's say, positive impact of listening music with the given frequency?
No. Okay. It makes no difference. It was more a stylistic kind of idea. In the Baroque era, people heard things a little higher. That was more pleasing to them. But it was more aesthetic. It had also something to with the instruments themselves, that kind of stuff.
Okay, that's it. Thank you.
Yeah. Okay, there's no more question. I'll tell you how NMT actually came into being. So I think you got the idea that there was research first. It was not creating some kind of intervention and then do research if that stuff works, which is always backwards. Doesn't work in any profession well. So we discovered, for instance, that the RAS phenomenon, we discovered that, and it's like, this is, wow. So we published it, and then we discovered some other things, and we published that. And we were sort of hoping this would be sort of trickling into professional practice. So I saw myself as a researcher. But so after several years going to these conferences, and we went to neuroscience and neurology and neuro rehab conferences, so basically the response was, we know that this works, and we have replicated it, and it's great. But we don't have any, especially medical directors, we don't have anybody who knows how to do that. So that was a completely new challenge. I hadn't really thought about that. I said, don't you have, do you have therapists? Yeah, you have a music therapist, but she does something completely different. She doesn't know anything about that. And then we have PT, OT, SLP. They have their specialties. They know a lot about that too, but they don't know anything about music and how that works. So there's sort of like a gap. And so this is when we had a little panel of experts and looked at the evidence that had been accumulated in favor of music applications and created 20 different techniques, one at a time. And then we created the Academy of Neurologic Music Therapy, which holds these 4-day certification courses in NMT for all rehab professionals and also rehab students. And so that's been going on for 20 years. And this is where I showed you briefly, there are about 4,000 NMTs in the world. So this is how that started. It was not my original intention, but we had to take some kind of educational step there because there was something missing from the research to the patient. And so this is why there's also an educational branch now attached to that, which I don't actually run, but I support that, of course. So that gives you a little perspective of how this NMT came into being.
If no more questions, thank you very much for your attendance and for your interest. And now we will have a break, I think, till 11:45, and then the workshop can begin. Thank you very much.
Thank you.